I'm Mark Leary. I'm the Deputy Chief of Psychiatry at Zuckerberg San Francisco General Hospital, and I want to welcome you all to this morning's grand rounds at UCSF Department of Psychiatry and Behavioral Sciences. And I'm especially pleased to welcome our own Dr. Loren Roth. Dr. Roth is Associate Clinical Professor of Psychiatry at UCSF, and she is the Medical Director of the Jail Behavioral Health Service at the San Francisco County Jail. Dr. Roth completed both her undergraduate and medical degrees at Tufts University and her psychiatry residency at New York University. She then completed a forensic fellowship at NYU before becoming the unit chief of a 29-bed forensic inpatient psychiatry unit at Bellevue Hospital in New York. During her time in New York, Dr. Roth also worked at the Rikers Island Jail facility. We were most fortunate to recruit Dr. Roth to UCSF in 2018 when she became the inaugural medical director of jail behavioral health for San Francisco. In the relatively short time that Dr. Roth has been medical director, the Jail Behavioral Health Service has become an important teaching site for UCSF psychiatry residents and medical students who are interested in correctional psychiatry. And it's become an increasingly active and critical part of our community public mental health system of care. Please join me in welcoming Dr. Loren Roth. And if you have questions for Dr. Roth, please submit them via the public chat box and we'll get to them after her talk. Dr. Roth.
Thank you for that very nice introduction. I'll go ahead and get started. I really appreciate being able to give grand rounds. And today I'm going to be talking about the concept of dual loyalty. So the title of my talk is Dual Loyalty, the San Francisco County Jail and Beyond. So goals and objectives of my talk. Well, the objectives, I hope that audience members will be familiar with the San Francisco County Jail as an important site for public psychiatric care in San Francisco. And I also hope that audience members will be able to define dual loyalty, name and recognize two examples, and also identify two ways to mitigate it. And in terms of goals, I hope that audience members will appreciate the robust mental health care services at the San Francisco County Jail and will be better able to recognize and navigate dual loyalty dilemmas they face in their own work. So these are a couple photos I actually took at Bellevue, where, as you heard in the intro, I both did my residency, my fellowship, as well as worked afterwards for 8.5 years. I really developed my interest and my identity as a forensic psychiatrist, and specifically as a correctional psychiatrist there. The unit where I worked was a very intense environment where the sickest and most dangerous patients from the jail are treated on a unit that's much like a regular psych ward, with a milieu and open doors and groups, as well as correctional officers posted at the ends of the hall. It was my introduction to a lot of ethically challenging scenarios, including dual loyalty dilemmas, a couple of which I'll be discussing today. So I want to introduce you to the San Francisco County Jail. First of all, just to distinguish between jails and prisons, I know some people maybe aren't quite sure what the difference is. So jails are run by cities and counties, and they house pretrial detainees as well as people who've been sentenced to shorter sentences of less than a year. Prisons are run by the state and federal governments, and they house individuals who've been sentenced to longer sentences, typically of over a year. So over the past 4 years here in San Francisco, the average daily population at the jail reached a peak in November of 2018 when it was 1,400. And the lowest point in that 4-year period was actually last summer in July, when the population went down to 700. Currently, our jail population is hovering in the 780s to 790s. On the day that I made this slide, there were 45 cis women, somewhere between 5 and 10 trans women, 2 trans men, and the rest were cis men. And I'm basing that on the fact that individuals are asked upon arrival at the jail what their gender identity is, what their preferred pronouns are, and what their preferred name is, actually. Obviously, this doesn't take into account people who identify as non-binary or other genders, so you can certainly take this with a grain of salt, but just to give you an idea. 58% of the population is 34 years old and under. I wanted to say a bit about the San Francisco political climate and how that kind of affects what goes on in the jail. So as I mentioned in the prior slide, the San Francisco political climate outside the jail impacts what goes on inside the jail. So the photo on the left here is the San Francisco Hall of Justice, and the 7th floor here of that building, facing Bryant Street, was one of our functioning jail units until November of 2020, when it was closed due primarily to being seismically unsafe. The plan to close that particular jail had been underway for years, and initially the plan was to replace it by building another jail. But there was a lot of political pressure and pressure from the community to reduce the overall jail population rather than build a new jail. Now the portion behind it over here that's facing the freeway, that's another one of our jail facilities, which is newer and which is still open. I'll be showing you a picture of that in a little bit. And then we also have a facility in San Bruno, which I'll also be showing you a picture of. Another thing I wanted to bring up here is that the Health Commission of San Francisco, which is the governing and policy-making body of the San Francisco Department of Public Health, adopted a resolution in 2019 establishing that incarceration is a public health issue, that there is a critical role for public health to prevent criminal justice involvement and address its negative effects, that there is the criminalization of race, homelessness, and poverty, and that substance use disorders and mental illness lead to incarceration. And finally, on this slide, obviously, is Chesa Boudin, the San Francisco District Attorney, who was previously the Deputy Public Defender. As you probably know, he ran for this office with a platform, a progressive platform, and certainly plans to reduce mass incarceration. So this is a cell, or what was called a tank, in the building I just showed you on the prior slide that closed last November. So what you're looking at is actually sort of an obsolete arrangement that is no longer what our jail looks like, but I wanted to show you anyway. So what you're looking at here is you're looking from a hallway through a couple bars into this tank, this cell. This is a 12-man cell. There's 3 bunk beds on this side, 3 bunk beds on this side. You can see it's not full. There's a toilet and a sink over here. On the other side of these bars over here on the left is a common area with a metal picnic table that's bolted to the floor, a TV on the wall, and a shower. And I actually have another photo of that to show you later. But again, as you can see, these were the living arrangements for most of the people in that facility of our jail that closed last November. Okay, I wanted to introduce you to Behavioral Health Court as well. Behavioral Health Court in San Francisco is a collaborative court that helps connect defendants with services in the community. It was established in 2002 in response to increasing numbers of mentally ill defendants in jails and courts. The mission is to enhance public safety and reduce recidivism of defendants who suffer from mental illness by connecting them with community treatment services, and to find appropriate dispositions to criminal charges by considering the defendant's mental illness. It's a collaboration between the San Francisco Superior Court, the DA's and public defenders' offices, probation, the Department of Public Health, jail reentry services, which I'll be telling you about soon, citywide case management, and others. So first, an individual has to have his or her case accepted into behavioral health court as both diagnostically and legally appropriate. And then that individual, it's voluntary to then have one's case heard in behavioral health court, which means that the person can then also choose to opt out and have their case heard in criminal court instead, if they so choose. The last time that numbers were collected, 52% of defendants whose cases were in behavioral health court were Black. There is a 60% graduation rate, and graduation means different things for different cases. It's in some ways decided upon on a case-by-case basis. 46% of clients who completed behavioral health court in 2018 were homeless upon entry, and 100% were housed at exit. The graphic here is from sfpublicdefender.org. It says behavioral health court graduation shines. This is an article about one of the annual graduation ceremonies that celebrates those defendant patient clients who finished their behavioral health court case. So you can't really talk about jail in this country without talking about race. So I'll do that a bit here. Now, in the first column, you see the racial demographics of San Francisco. I think, as you probably know, Black people make up quite a small percentage of people in San Francisco. The second and third columns are jail intake and jail population. So let me just explain that for a moment. Jail intake is those people who are taken to the jail upon arrest. However, not everyone who is taken to the jail upon arrest stays at the jail. Some people get what's called cited out, which means they get a citation saying that they have to appear in court soon, but they don't have to spend time in jail. So as you can see, Black people make up 36% of those at jail intake, but they make up 47% of the jail population. So as you can see, Black people are being cited out less frequently, whereas white people make up 28% at jail intake. That goes down to 22% in the population, similarly with Latinx people. That fact probably doesn't surprise you, knowing what we know about the mass incarceration of Black people in particular. And I was reading an article in the New Yorker from last summer, and I came across this quote in an article by Jill Lepore that's from 1922, almost 100 years ago, and it pertains today. So I will read it here. Negroes are more commonly arrested, subjected to police identification, and convicted than white offenders. And on similar evidence, they are generally held and convicted on more serious charges, and they are given longer sentences. These practices and tendencies are not only unfair to Negroes, but weaken the machinery of justice. And that is from a report written by the Chicago Commission on Race called The Negro in Chicago, A Study of Race Relations and a Race Riot. Okay, so Jail Health Services is the healthcare workforce at the jail. Jail Health Services is a division of DPH, and Jail Health Services staff members are employees of DPH, except for us psychiatrists who are faculty at UCSF. Jail Health Services includes primary care, psychiatry, HIV specialty care, OBGYN, dental, pharmacy, and physical therapy. Medical and surgical specialty appointments for patients are done at CSFG. As of recently, we have started to offer neuropsych testing for jail patients, which is new. Buprenorphine and methadone are offered at the jail. A few weeks ago, grand rounds here in our department was by an addiction psychiatry fellow who presented on the topic of buprenorphine at the jail. It's beyond the scope of my talk to go into detail on that. We have a Jail Health Services Racial Equity Work Group, much like other divisions within DPH and UCSF as well. We are working on addressing racial inequity, both in terms of the Jail Health Services workforce, as well as in the work we do serving our patients. We also have set aside time in various standing clinical and administrative meetings throughout jail health to educate each other on racial equity issues. So for example, recently it was my turn to present a couple months ago, and I did a brief presentation on reparations for Black Americans. Another coworker recently presented her portion on the practice of redlining. Someone else presented on a YouTube video that was a discussion among Black people and Asian people about the racism and hate they've each experienced. So that's kind of a really important practice we've started in our standing meetings. Finally, this pie graph shows the demographics of the healthcare workforce. As we know, it's important for our healthcare workforce to reflect those we serve. The jail health services workforce is certainly diverse, but it does not exactly reflect the population we serve. Jail Behavioral Health Services is the subdivision within Jail Health Services that provides mental health care at the jail. This photo here is from a recent staff outing we did to mini golfing. At this point in time, we are 19 clinicians, so MFTs and social workers, 5 health workers, and then we are 2 psychiatrists with a 3rd one starting soon. Jail Behavioral Health Services staff members provide mental health services throughout the whole jail system here in San Francisco, but I did want to highlight psych housing areas. Psych housing areas are areas within the jail where mentally ill patients are sort of cohorted or housed together in the same area. There is kind of a milieu, there are groups run in the area, there are dedicated jail behavioral health staff members providing care there. There are typically deputies working in those areas who have received a bit more training on working with mentally ill patients than other deputies have received. So that's a bit about our psych housing areas. We have robust coordination with PES and 7L at DSFG. 7L is our acute inpatient psychiatric unit for the jail that has 6 rooms. PES is, of course, where our jail patients on 5150 are taken. Jail reentry services is a bit like discharge planning on an inpatient psych ward. The difference is that the capacity and the nature of the work of jail reentry services is such that not everyone who leaves the jail gets reentry services. It's primarily geared towards people who have serious mental illness. And then just to give you some numbers, 53.5% of people at the jail are under some form of behavioral health services care, and 26% are on psych medication specifically. So one of our health workers at the jail is a particularly good artist, and he uses this whiteboard when he runs groups. So I thought I would show you some of these. On the left, it says suicidal thoughts. In the middle, it says marijuana and mental health. And on the right, it says cellmate issues. Some of the groups are on, topics relating to coping skills that people need to use when they're living in jail, such as cellmate issues. So that's one topic. So I mentioned earlier that we have a building in San Bruno, so I'm going to kind of walk you through this picture here of one of the pods in our San Bruno facility. So we call this a pod. Now, first of all, this photo was taken on a day when there were no inmates in here. These are some sort of visitors. I don't know who they are, but this pod was not actually in use. So we call this a pod. Down here are 12 2-person cells, and up here are another 12 2-person cells. This is a common area. If this were a psych housing unit in particular and groups were being run, the group leader would stand up here. Off camera over here, there is a large cement gym with a basketball court. These are payphones. Phone calls for inmates in the San Francisco County Jail are free. This is a podium where the deputy sits. This is another podium where the deputy could sit, but they don't actually use that podium. Here are a couple interview rooms. Back here is a medical exam room with an exam table and some basic medical supplies. So this is a pod. There are 16 pods in San Bruno. San Bruno houses around 550 inmates. It's the larger of our 2 currently functioning buildings. So I thought I would take this opportunity to just run through kind of a typical day. So in the morning, I will check the list of patients waiting to be seen that day and prepare to see the patient. Typically, a significant portion of the people I'm going to see are people I know, either because they are follow-up appointments or they are appointments for someone whom I know from a previous incarceration in the past. So you enter the pod over here by buzzing the door, and a deputy in a control booth elsewhere in the building sees me from a camera in the ceiling and lets me into the pod. and then I ask the deputy at the podium if I can see the patient in an interview room. And then I go from pod to pod and see the patients that I need to see that day. I'll also add that there's a lot of collaboration with our jail behavioral health services coworkers as a psychiatrist, much like on an inpatient unit, sharing impressions and ideas about the patient's progress and their current presentation. It works much the same way with us, very, very collaborative. This is a photo of a pod in our building in the city, the one I showed you that faces the freeway. So in this particular pod, you can see there's no doors. This is a dorm setting. This is a bunk bed. This is a bunk bed. These are all bunk beds up here. There's bunk beds down there. And this is the podium where the deputy sits. So this particular pod is more of a dorm setting as opposed to cells. I wanted to put up a slide about the COVID-19 pandemic at the San Francisco County Jail. Obviously, it could be an entire presentation in its own right, but just a few quick facts. We started offering testing to all arrivals at the jail in April of last year. There's been a whole lot of energy and time devoted to making arrangements and staying on top of quarantine and isolation, as well as, of course, identification and isolation of positives. We have not had any outbreaks during the pandemic at the jail. The maximum number of positives that we had at any given time was 9 patients, and that was in January of this year. We started vaccinating patients on January 24th of this year, and there's been really excellent vaccine education for patients at the jail done by jail health services staff, which has resulted in really excellent vaccine uptake at the jail. Okay, so moving on to the next part of my presentation. So I wanted to introduce the idea of dual loyalty and dual loyalty dilemmas. I'm not sure if you're already familiar with the concept. So a dual loyalty dilemma is a dilemma involving a clinical role conflict, so almost like a conflict of interest between professional duties to a patient and obligations, explicit or implied, to the interests of a third party, such as the sheriff's department, the state, an insurer, the military, etc. The dual loyalty can be either perceived or real, as I think I'll show you with examples in the coming slides. So I'll start with an example in the military. The Army Medicine Service in the military has a mission, which is to provide sustained health services and research in support of the total force to enable readiness and conserve the fighting strength while caring for our people and their families. Now, as you can see, a doctor in the Army is tasked with caring for people and their families, but is also tasked with conserving the fighting strength and enabling readiness and conserving the fighting strength. And you can imagine how there might be some scenarios where those two aspects of the mission are in conflict. And that would be a dual loyalty dilemma. Another example, in Afghanistan, a quote unquote enemy prisoner of war wished to die rather than be taken prisoner and was given dialysis against his will in order to allow him to stay alive for thorough interrogation. So again, the doctor in that situation, taking care of that dialysis, has a dilemma between doing what the patient wants versus keeping that patient alive for thorough interrogation according to the directions of his or her boss, supervisors. Torture is certainly a very stark example of dual loyalty. This graphic here is from a conference in 2016 that was hosted by Fordham University called Professionals Speak Out About Torture and Dual Loyalty Conflicts. Another example of dual loyalty dilemma comes up for doctors who work in states with restrictive abortion laws, gag rules, which are laws that dictate what a doctor can and can't tell her patients about reproductive healthcare options. as well as ultrasound laws that dictate when an ultrasound has to be done, even if it's not medically necessary. So doctors in these states probably face situations where they have to choose between doing what's right for their patient, that they and their patient decide is what's right, versus doing what the state dictates. So in this case, we're talking about a dual loyalty dilemma in which the doctor is legally mandated to choose one action over another. And legal mandates are, of course, one factor to be taken into account when deciding how to resolve a dual loyalty dilemma. However, as we know, a legal mandate may still be unethical. Here are some more examples I'll run through. So, immigration detention. Doctors in immigration detention are employed by ICE or agencies within DHS. So they are working essentially in service to ICE or DHS. And that might create conflicts occasionally between serving the patient versus serving ICE. The pandemic. During the pandemic, doctors had to choose between making decisions that served the community at large and the spread of COVID versus working in service solely to the person sitting in front of them, the patient sitting in front of them. Managed care. Managed care puts doctors in positions where they feel pressure to work in service to the financial efficiency of the healthcare system. Forensic evaluations. So as a forensic psychiatrist, we are taught from the get-go in forensic training that you cannot do a forensic evaluation for the court on someone who is also your patient in a treatment setting. Forensic evaluations are done in service to the court, not to the patient that you are treating. For-profit healthcare providers in jails and prisons. Doctors who work for these agencies are employed by a company that relies on mass incarceration to stay afloat. So in those situations, doctors are perhaps forced to make decisions between what is best for the patient and what is best for this company that relies on mass incarceration. So I have another example, which is TARASOFF, and I'm going to put that up here as a poll. I don't have the technology to actually collect your responses, but I will be showing the poll up here and you can register your answer in your head. So as I think many people know, TARASOFF is a court case from the 1970s that established that doctors have a duty to warn and a duty to protect a potential victim of their own patient. If your own patient has violent ideation or violent intent, we have a duty to warn and a duty to protect the potential victim. So who is the third party in the dual loyalty dilemma of making a TARASOFF report? So I'll put your options up here, and then you can think about which one it is. Okay, so the third party in the dual loyalty dilemma of a TARASOFF report is the potential victim. And what I mean by that is, when making a TARASOFF report, you are acting in service of the potential victim rather than the patient in front of you. You are weighing the pressures you have to act in service of your patient versus acting in service of the potential victim. So moving along to dual loyalty dilemmas in jail. Jails are totalitarian repressive institutions where structures to support the human rights of patients are limited to non-existent. Patients are vulnerable, they are reliant on the healthcare provider, they lack choices about whom they can see. Clinicians in jails face pressure to participate in institutional security and cost cutting. We face pressure to put aside the primary goal of patient care for the interests of the security mission. I will also say that working in a jail or in a jail environment for a long time, you are working side by side with deputies. You rely on them for safety at times. They are your coworkers. Perhaps in some cases you might socialize with them after hours, become friends with them, maybe marry one of them. Seen that before. And so I bring that up because it can be more complex or more difficult to resist pressure from this third party when, again, its representatives are your coworkers, your friends, etc. Now, I did want to point out that one of the articles that I really relied on and really turned to for this whole topic and this presentation in particular was an excellent article called Data-Driven Human Rights, Using Dual Loyalty Trainings to Promote the Care of Vulnerable Patients in Jail. And it was written by clinicians and healthcare administrators at Rikers Island in New York City, the jail system in New York, in 2015. And they conducted an evaluation of the extent to which the mental health service is involved in assessments that are part of the punishment process of the security apparatus. And so I'm going to go over a few more examples, some of which I got from that article. So dual loyalty dilemmas in jail specifically. Okay, so this first example, I got from this article I just mentioned. So let me explain this. Clinician clearing a patient for solitary at Rikers Island. So what that means is that in the past, this is not a current practice because it was found to be too problematic, but in the past, when the corrections officers at Rikers wanted to put someone in solitary, they would present that patient to a clinician, asking that clinician to quote unquote clear that patient from a medical and mental health perspective for solitary. Now, this was ostensibly done to protect the patient, but as you can imagine, this is an extremely problematic position for the clinician to be in because he or she is then given the role of essentially greenlighting this person going into solitary. A very problematic scenario. Again, it was eventually abolished because it was thought to be so problematic. Another scenario that came up in this Rikers article, patient asking clinician for a condom. So the scenario as portrayed in the article was that during the course of a clinical visit, a patient asks the clinician for a condom. Now, at the jail, at probably any jail, inmates having sex with each other would be considered a rule violation from the perspective of the corrections officers. So in this scenario, a patient asks for the clinician for a condom in the course of a clinical visit. And the clinician then makes a choice about whether or not to report this rule violation to the corrections department. In the article at Rikers, they polled a subset of the healthcare workforce, and 27% said that they would report that. Now, of course, that means that more than 70% said they wouldn't report that. And so the majority found that this is a piece of information that should remain confidential and should not be shared with the corrections department. But again, it sounds that is a dual loyalty dilemma where some clinicians feel pressure to report and then some do not report. Okay, a few more examples. Patient reports to clinician he has a shank. This came up multiple times for me at my time at Bellevue. A shank is as you may know, a piece of wood or plastic or glass that's been fashioned into a potential weapon. So this came up a few times for me at Bellevue. A patient would reveal in the course of a clinical visit that he has a shank in his belongings. We would then be weighing the risk of either breaching confidentiality and sharing that information with the corrections department who's on the unit to have them remove it versus allowing the patient to keep that a secret and not revealing that piece of information to the corrections department. I can say that most of the time when this came up, we would report this because we decided that the safety of other patients on the unit and staff on the unit took precedence in this situation. Patient reports he's using drugs in jail. This comes up occasionally these days. Drugs are certainly all over the jail. Obviously, having drugs in jail would be considered a rule violation according to the Sheriff's Department here in San Francisco, as with anywhere. If in the course of a clinical visit, a patient reports to us that he is using drugs in the jail, I can say that typically we do not share that with, I think I'm speaking for my coworkers when I say that typically we do not report that to the Sheriff's Department. And, you know, one of the differences is that although drugs are certainly dangerous, they are not an instrument of violence as a shank is. Clinician witnessing and reporting abusive deputies. Now, obviously it is vital to report abuse when we see it. But I will say that some people who work in a jail in a clinical capacity feel that it can be intimidating to report. They can be on the receiving end of retaliation if they report abusive deputies. Again, deputies are people whom they occasionally rely on for safety. So it's fair to say that some people who witness abuse experience a kind of dual loyalty dilemma on whether or not to report it. Deputies' presence during pill call. So pill call is done, or med pass, whatever you want to call it, is done at the jail similarly to how it's done in the hospital. A nurse walks around with a cart, passing out pills from cell to cell. A deputy is always present during pill call. That is, the Sheriff's Department dictates that a deputy has to be present because the Sheriff's Department is invested in the idea that there aren't a whole lot of pills floating around the jail. They're invested in the idea that patients are swallowing pills when they're given the pills. I don't obviously do pill call myself. That is a nurse's duty, but I can certainly imagine that as the nurse is carrying out this clearly medical task of passing pills, having a deputy right there probably presents the nurse with certain dual loyalty dilemmas where he or she may experience pressure from the deputy to do things a certain way or not do things a certain way while he or she is, again, executing this medical task. And finally, clinicians deciding who is authorized to carry a cane or be spared from certain kinds of restraints. So at a jail, if you need to carry a cane or if you have a broken arm or wrist and you can't be handcuffed in the same way that people are typically handcuffed, you require a note or permission from a clinician for the Sheriff's Department to make that exception. Probably sounds pretty straightforward. Either you need a cane or you don't, but clinicians in those scenarios occasionally face dual loyalty dilemmas where they feel pressure from the security apparatus to make a certain clinical decision versus making a clinical decision purely in service to the patient. I wanted to bring up another dual loyalty dilemma, or a dilemma which certainly has a lot in common with the dual loyalty dilemma, although perhaps a little bit different, but I'll explain it and perhaps you can see what I mean. I told you a few slides ago about behavioral health court. Again, I put an asterisk here because it's a little bit different than the dual loyalty dilemmas I've been telling you about. But basically, so as I explained, behavioral health court patients who are accepted into behavioral health court, they agree to have their treatment monitored by the court as part of participation in behavioral health court. Their treatment starts in the jail, continues in the community, and it is monitored by the court. That's part of the agreement. So in this scenario, this is not a particular patient, but this is sort of a composite of patients I've treated. So in this particular scenario, the patient is on Zyprexa and insists that 5 milligrams is the highest dose he'll take. However, 5 milligrams is not enough for my assessment. I think he should be on 10 or 15 milligrams. And the patient tells me that if I raise the dose, he's going to stop the medication. And if he stops the medication, then he is at risk for essentially having his case taken out of behavioral health court. So, and his adherence is tracked by the court. So you can see that this decision about the Zyprexa, which would in theory, be a dyad between me and the patient, making a decision about the psychiatric. It's no longer really a dyad, right? I become sort of an unwitting actor or player in the legal situation in terms of my decision about what to do with the Zyprexa dose. So again, it's complicated, and it is a bit like a dual loyalty dilemma. Few examples outside of the jail that I wanted to go over. I spoke with one of our colleagues in the ZSFG emergency department, and I asked him about whether or not his staff typically asks the sheriff's deputies to step away when they're evaluating a patient in custody. And he said that some do and some don't. In some situations they do and in some they don't. And I think that right there is a dual loyalty dilemma. That question in the doctor's head, am I going to ask that deputy to step away or not? Am I going to prioritize confidentiality, or at least try to? Or am I just going to let the presence of the deputy, go and let the deputy be there without any questions asked? In one study, only 7% of physicians always ask deputies to leave the room during the exam. So that is an example of a dual loyalty dilemma in the moment. Another scenario that came up in my conversation with this ED doctor that he described, a scenario in which he's treating someone who's brought to the ED for a motor vehicle accident. The police are not involved, or if they are, they don't know that this person has an elevated blood alcohol level. And so this doctor told me that he, at least earlier in his career, struggled with the question of whether or not to report this patient. The idea being that the doctor would be sort of doing a service to the community at large by getting this drunk driver reported to the police, versus, of course, keeping that piece of clinical information confidential in the course of that visit. So as we know, doctors are not in the business of law enforcement, but it is a question that comes up, at least for this particular doctor. So talking about mitigating dual loyalty in jail. This is a picture of Rikers Island. Again, I relied on this excellent article that I mentioned earlier. So healthcare workers should act exclusively as caregivers, and medical tasks required by the security system, the prosecution, the court, etc., should be carried out by professionals not involved in the care of patients. We need to have education and training to spot dual loyalty scenarios for learners and those working in jails and prisons. It's important that we recognize when we are trying to accommodate our medical skills to the limitations imposed on us. It's important to recognize when we have problematic contractual obligations, overt or concealed pressure, even just habit. It's important to recognize when peer supervision could be helpful. Obviously, going to one's supervisor or boss is helpful, but even in the moment, peer supervision can be helpful. I came up with these 4 words under the heading of advocacy. We hear a lot about advocacy and medical student training and residency and beyond. And I think that there's a form of advocacy that can be done here. So I'll run through my list here. Education. Educating deputies can help them understand why we're pushing back or making certain requests or advocating for the patients repeatedly in a way that conforms to our healthcare mission. Escalation. Escalating an issue to my boss or to a particular deputy's boss can help in making systemic changes in favor of the patient's needs rather than just putting out a fire in the moment. Consistency. If different clinicians respond to dual loyalty dilemmas differently, it may lead the sheriff's department to not recognize how serious we are about our healthcare mission. And finally, semantics. I think words are important. We call them patients and clients. We do not call them inmates. I've come across other jail psychiatrists and psychologists across the country who refer to them as inmates. I think semantics are important. Some more questions and issues in mitigating dual loyalty. Is the demand of the state or third party justifiable and consistent with human rights norms, or should the demand be resisted? Now, some ethical dilemmas are resolved in favor of society's greater good, as I think I've illustrated here with some of the examples. Not all dual loyalty dilemmas involve human rights violations. And there is a quote I came across from the International Dual Loyalty Working Group in 2008, so I'll read that. In all circumstances where departure from undivided loyalty takes place, what is critical to the moral acceptability of such departures is the fairness and transparency of the balancing of conflicting interests and the way in which such balancing is or is not consistent with human rights. Another topic in mitigating dual loyalty, training and education. I came across this excellent article by Atkinson about a dual loyalty training curriculum at the Icahn School of Medicine at Mount Sinai. In this program, they define dual loyalty for students. They explain key ethical principles involved. They identify situations that present the problem of dual loyalty and clarify responsibilities of healthcare professionals. One of the examples mentioned in the article was the example of a shackled, pregnant, incarcerated woman. And then the students break out into groups and they come to understand the ethical obligation to support colleagues, transform institutions, and address the problem of dual loyalty at a systemic level. I wanted to actually bring up something that I got from the Black Study Group report right here in our department. This was the Black Study Group report for the chair of our department that came out in October of last year. And I was reading through it and I found a few quotes that I thought were pertinent here. So I'm going to show you that and then kind of tie everything together a bit. So this is a quote from a trainee who's quoted in the Black Study Group report. This is a trainee here at UCSF on an inpatient psych unit. I was assigned to a patient. I did notice some kind of charged language, a lot of focus in the one-liner on his past history of assaultive behaviors, this gun charge. And when I delved into the social history, it just wasn't very relevant for the mission. The patient was very pleasant and very nonviolent, and the charges had been like over a decade ago. This is an already stigmatized man, a Black man. I ended up presenting the case. The attending was totally supportive of the idea of structuring a discussion around bias in the medical record. So with that, I want to kind of tie everything together around race, bias, incarceration, and dual loyalty dilemmas. First, I'll just show you what's on this slide. This is the other side of that tank, that cell that I showed you in the very beginning. This is our County Jail 4, the facility that closed last November. This is the common area. The Chronicle did not obscure these men's faces, but I did so here. Anyway, so to tie together these various threads, race, bias, incarceration, and dual loyalty dilemmas. We know that Black and brown people are incarcerated at very high numbers. We know that they face bias and discrimination both in the jail as well as once they leave the jail, as noted in the prior slide. We know that dual loyalty dilemmas in jail are especially difficult, thorny, and impactful for the patient. And so if we truly want to serve all our patients at the jail, including our vulnerable Black and brown patients, and provide them with the human rights-centered, compassionate care they deserve, then we need to devote time and energy to how we approach and try to resolve dual loyalty dilemmas. So with that, I want to say thank you to my friends, colleagues, and supervisors in New York, Elizabeth Ford and Jeremy Colley. I want to thank Mark Leary and Jim Dilley, both of whom hired me, and all of my jail health services coworkers here at the jail. I will say that I really collected a fantastic list of resources on the topic of dual loyalty, which I would be happy to share. Really excellent articles out there. So yeah, with that, I would love to take questions if people have any.
Thank you, Dr. Roth, for a fascinating and informative talk. That was great. We do have, understand Dr. Lee, Descartes Lee has a question that he wanted to ask you directly.
Hello. Thank you so much, Loren, for a great talk. This is one of those rare instances where I think someone in the audience is going to foreshadow his own Grand Rounds presentation next week by making a comment and asking a question at this week's Grand Round. So, next week I'm going to talk about professionalism and and I'm going to argue, and in some ways it really overlaps a lot with your talk on dual loyalty, that in some ways navigating these dual loyalties and conflicts, I would say it's part of professionalism. But I think the point I would want to make would be that it really is a complicated set of competencies and expertise that you actually develop to navigate these dual loyalties and conflicting values that you have to deal with. And sometimes it's like taking a systems point of view and trying to avoid that conflict that you're in. So I think that's, I really appreciate that discussion. I thought it was really fascinating. The other point that I'm going to make is to thank you for your teaching of all the trainees in that setting. It's so critical. And the other point I'm going to make in my professionalism talk, and I'd like you to, and you kind of alluded to it this time, maybe you can talk a little bit more about, we kind of have a dual loyalty in as teaching faculty, as teachers, as well as clinicians. And sometimes we have patients and students. Fortunately, most of the time, 99% of the time, if we provide good clinical care, that's also good teaching. So there isn't a conflict there. But sometimes there is a conflict when we have to look after the well-being of the trainee, for example, or think about their education. I don't know if you had more to say about, do you think, it seems like the jail has yet another level then when you have trainees there. So interested in your comments on that, and I'll take it from.
So you're saying specifically the topic of teaching at the jail and whether or not that brings up unique dual loyalty dilemmas for us?
Yes. One thing that I'll argue in the my Grand Rounds next week is that one of the key things has been a common thing is when we have abusive patients, not in the jail setting, but I don't know if that has occurred, and if it has or hasn't, what do you think the factors that lead to that? I mean, in some ways we can protect ourselves, but trainees are like they're our responsibility.
Yeah, I mean, I have to be honest, I haven't. I look forward to your talk because I haven't actually thought a lot about dual loyalty dilemmas that come up with teaching. I mean, I guess maybe what the kind of dual loyalty dilemma that comes up would be, for example, if a patient does not want the trainee present, but we want the trainee present because it's a valuable teaching experience. So do we sort of grant the patient his or her wish to not have the trainee present and sacrifice the training, or do we say to the patient, you need to have the trainee present? So that's, I guess, maybe what you're talking about, or that's an example in general of maybe a dual loyalty dilemma in teaching. It's hard. I'm having trouble thinking of one such. What I will say is that I think that, although I don't know if I have a specific answer for you, I will say that patients at the jail are probably even more suspicious of new clinicians coming into the picture. They are probably understandably more hesitant to have new parties entering the clinical visit. The jail is already, again, a repressive environment. Maybe they're suspicious of what the intentions of that person is who's entering into the clinical visit. And so I'm not sure if I'm giving you a specific scenario. I'm just saying that these are some of the complications of trying to bring trainees into the jail, is that there could be almost like an added level of suspiciousness around the trainee's presence.
All right. We have another question from Dr. Cynthia He. I'll read it to you now, Dr. Roth. Thank you for this talk and for bringing in the topic of dual loyalty. Curious if you can comment about how to navigate the dual loyalty issues that arise when we are assessing violence risk in the acute setting, especially when race and socioeconomic disadvantage are also factors at play. While we are not law enforcement, it can seem that violence risk assessment often forces us into a law enforcement adjacent role.
Law enforcement adjacent role. So sorry, is this, I didn't hear who was asking this question. Is this
Dr. Cynthia He, who's one of our UCSF psychiatry residents.
Oh, okay. Yeah, I mean, I guess that reminds me a little bit of my example of, I mean, there's the TARASOFF example, there's the example of a patient on the inpatient unit at Bellevue having a shank. I mean, it's interesting. I guess I'm not sure I necessarily view a violence risk assessment as being law enforcement adjacent. I think that, I guess part of me is wanting a little bit more detail from this question. I wish I could ask more of the question asker about what she means. Yeah, I mean, I definitely think that a kind of dual loyalty dilemma comes up when doing a violence risk assessment. Yes, because you are trying to weigh one of the things you're weighing is the potential danger that this person in front of you will inflict upon third parties who are not your patient. So yes, certainly that is fair. It's sort of a dual loyalty dilemma. But I guess, again, I'm not sure I view myself as being law enforcement adjacent in that case. I guess I feel that I'm comfortable with the idea that doing a violence risk assessment can and should be a clinical exercise. So again, I perhaps sometime I can chat with this person who asked the question and maybe get into more detail about that.
All right, and Dr. Jim Sorensen says, excellent presentation. In working with people treating substance users, many of the same issues arise, particularly when the patient is in court-appointed treatment. The counselors have the same dual loyalties as the physicians discussed this morning.
Yeah, anytime you overlap with the courts, which we sometimes do as physicians, right? Anytime you overlap with the courts, it's complicated, and you have to think hard about your own role and what the limits of that role are.
And a comment from Tanya Mera, the Director of Jail Behavioral Health. We face similar issues documenting violent behavior in our jail charting. It could be incriminating.
Yes, thank you, Tanya. Tanya is absolutely, that's an excellent point that I'll just make, because this actually applies outside of the jail as well. When you are seeing a person, again, an ED, the PES at the jail, who's been arrested for a violent crime, the way you choose to document can be complicated. Your records could be later subpoenaed. And if you quote the patient as he or she is essentially admitting to the violent act, the crime, and you write that in the record, you quote the patient in the record, and then those records are later subpoenaed and used against the patient, then we as physicians are supposed to do no harm. Well, then in a way, you've sort of gotten into, your records have gotten into the realm of essentially perhaps doing harm to that patient by getting them incarcerated or whatever the case may be. So yes, documentation is absolutely a complicated scenario that comes up here.
And then from Dr. Jake Eisenberg, also a psychiatrist and UCSF faculty member at the jail, a violence risk assessment can also be viewed as protecting the patient from the consequences of engaging in violence as a result of a psychiatric condition. Can you speak to formulary restrictions as a manifestation of dual loyalty? This is something we deal with in the jail, but is also an issue in other systems of care, particularly public systems of care. Also, is there a distinction between dual loyalty and the bioethical principle of justice?
Yeah, formulary restrictions is kind of a big topic at the jail. So one of the issues that comes up at the jail is that diversion of medications gets extra complicated because it is an enclosed sort of ecosystem. And so medications that are frequently diverted and have a high street value at the jail are sometimes limited in terms of being restricted from our formulary. And so the dual loyalty dilemma that comes up then, deciding on what's in the formulary, is, do we offer our patients everything that's out there, everything that's available, everything that we can, or do we respond to the problem of diversion at the jail and thus limit those medications which have a particularly high street value, or a particularly high street value and which are often diverted? So those are some of the dual loyalty dilemmas that come up with formulary restrictions at the jail.
And Dr. Roth, it's just past 9:30, so I'm afraid we're going to have to stop there. Thank you again for a great talk, and thank you all for your questions. Have a great day.
Thank you.